Hello, everybody. My name is Dr. Sudha Seetharam. I am MBBS from Medical College, Kolkata, and MS Ophthalmology from Maulana Azad Medical College, New Delhi. And I am the ophthalmology educator for this clinical case discussion. And with me, we have a very bright medical student and soon to be doctor, Meghanshi Rajput. And together, we will be discussing some common and important cases in ophthalmology. So, Meghanshi, let's proceed with the case.
So thank you, ma'am. So we are clinically case discussion on pseudophakia. So my patient details: a 72-year-old male resident of Jaipur, a retired bank manager, and he's a self-informed, so he's reliable. He has A positive blood group and he belongs to middle class by socioeconomic status. Then the chief complaints of my patient: gradually progressive blurring of vision in the left eye for past 3 months, difficulty in seeing at night, and halos around light at night.
Okay, so let's proceed to the presenting illness.
Yes, ma'am. So history of presenting illness: the patient had undergone cataract surgery in his both eyes 2 years back, and he was having good vision in his both eyes till 3 months back when he started experiencing difficulty in vision with his left eye. The vision in the left eye has been progressively deteriorating for the past 2 months, and patient also complains of spreading of light and halos at night.
Okay, so this patient had actually undergone cataract surgery in both the eyes 2 years back, and then he was enjoying good vision in both the eyes. He had no complaints. But then for the past 3 months, he's telling us that gradually the vision in the left eye has started deteriorating. And not only is he experiencing difficulty in vision, he has particular problem when he's driving at light. And he says that there are halos around the bright light, which is suggestive of scattering of light. Right?
Yes,
so now, Meghanshi, I want you to think and tell me what can be the possible cause of the decrease in vision in a patient who has undergone a cataract surgery previously and he was enjoying good vision. So what is the possibility of a gradually progressive loss of vision in an eye which has previously been operated for cataract?
More commonly, as he's been operated for cataract surgery, there could be posterior capsular opacification. And then there could be some unrelated causes as well, like age-related macular degeneration or diabetic retinopathy.
Correct. So basically, when we talk of a patient who had undergone a good cataract surgery and was enjoying good vision for a reasonable amount of time after cataract surgery, like in this patient 2 years, then he started having difficulty in vision, we can think that it may be because of posterior capsule opacification, PCO, which was previously called as after cataract. Now see, when we do a cataract surgery, what are we doing? We are creating an opening in the anterior capsule, which is called as capsular excess. And through this, we are removing the opaque or the cataractous crystalline lens. But we are leaving behind the capsular bag. Why do we leave behind the capsular bag? Because we want to place our intraocular lens inside this capsular bag. Right? So once we have done that, we are leaving behind this capsular bag, and sometimes months or years after cataract surgery, this posterior capsule can also become opaque due to the proliferation of the remaining lens epithelial cells. And this PCO, once again, it causes obstruction of the light rays in the visual axis and can cause decrease in vision. So one of the most common late complications of a cataract surgery is posterior capsule opacification. And this is further suggested by the fact that the patient is complaining of glare and halos, which is a sign of light scattering, which is also an important complaint of PCO. So when we look at this history, we think that probably it may be PCO. But as you told me, it is also possible that he may be having some unrelated posterior segment pathology, like maybe diabetic retinopathy or age-related macular degeneration, or some other cause which is unrelated to the cataract also is possible. Right? Yes. So let's proceed to the rest of the history.
And then personal history: he consumes mixed diet and normal appetite. He's a non-smoker but drinks alcohol every alternate day from the last 40 years. He was diagnosed with diabetes mellitus type 2 at the age of 49 years.
Okay, so let us summarize the history of this patient.
To summarize my case, a 75-year-old male patient, known case of diabetes mellitus with history of cataract surgery in both the eyes 2 years back, presents with gradually progressive decrease in vision and glare in the left eye from the past 3 months.
Okay. So now we'll proceed to the general examination and then the ocular findings.
Yes, ma'am. To begin with general physical examination, patient is conscious, oriented to time, place, and person. Weight 75 kg, height 166 centimeter. Vitals, temperature 98.1 degree Fahrenheit. Pulse rate 72 beats per minute, regular in rhythm. Blood pressure 110 by 60 mmHg. Respiratory rate 18 and SpO2 97% in the room air.
Correct. So basically the general physical examination is normal. Let's proceed
Yes,
to the
ma'am.
ocular examination.
And then ocular examination, visual acuity aided in right eye 6 by 9, in left eye 6 by 24, not improving with pinhole.
Right. So what does this suggest to you? That the left eye visual acuity is not improving with pinhole. It is decreased but not improving with pinhole. What does this mean?
So it is not improving with pinhole, so it is not due to uncorrected refractive errors.
Correct. So if it had been due to an uncorrected refractive error, we may have a decreased visual acuity which is aided or unaided. And if it is incorrect, it is not completely corrected, then it will improve with pinhole. That means it requires further correction. So there is no uncorrected refractive error which is the cause of this decreased visual acuity. There is some
Yes, ma'am.
organic pathology. So let's find out what is the pathology. Go
Yes,
ahead.
ma'am. Then extraocular movements, lids and conjunctiva, they are normal in both the eyes. Then
Okay.
cornea, it is clear and there is a linear scar on temporal side in both the eyes.
Okay, so what does this suggest to you, Meghanshi, that there is a linear scar on the temporal side of the cornea in both the eyes?
Ma'am, it basically suggests as he has undergone the cataract surgery, so that is entry wound during that cataract surgery.
Correct. So this is the entry wound of the cataract surgery. So we see a linear scar which is on the temporal side. So can you tell me what kind of cataract surgery do you think that the patient has undergone?
Ma'am, according to this examination, it is suggestive of phacoemulsification.
Correct. So, see, phacoemulsification cataract surgery is the most commonly done cataract surgery. And here we have a clear corneal incision. That is, the entry into the anterior chamber is generally through the clear cornea. And generally, we prefer a temporal position of the incision. So, the patient lies like this. We sit on the temporal side of the patient. And we make an entry through the clear cornea on the temporal side as is suggested in this case. Now, given the phacoemulsification cataract surgery is an equipment-based surgery, right? It requires the phacoemulsification machine, which is required. But given the large volume of cataract that we have, and there may be smaller rural centers where these machines are not available. So, in our country, we are also doing small incision cataract surgery, which is a manual type of cataract surgery. But from this patient, we can understand that this is not SICS because in SICS, the incision is generally superior. We have a superior location of the incision, and that's also not a clear corneal incision. It is a posterior limbal or a scleral incision. So we make a posterior limbal or a scleral incision, and we make a sclerocorneal tunnel and then enter into the anterior chamber. So if at all you see a scar, it will be a superior scar in case of SICS, whereas this patient is having a linear temporal scar on the cornea, which suggests that he has undergone phacoemulsification cataract surgery.
Yes, ma'am.
Okay, chalo, let's proceed with the rest of the examination findings.
Ma'am, then anterior chamber, it is normal in both the eyes. Pupil, it is round, regular and reacting to light. And then lens, it is posterior chamber IOL and C2 in the right eye. And in left eye, it is posterior chamber IOL and C2 and there is posterior capsular opacification. And fundus is normal in both the eyes.
Correct. So just as we had assumed from our history, we have a well-centered PCIOL in C2 in the right eye, which is giving good vision to the patient in the right eye. However, in the left eye, the patient has an IOL in C2, but at the same time, there is a posterior capsule opacification, which was giving rise to the symptoms of glare and halos and the decrease in vision. And we had thought that we may be having some unrelated fundus pathologies, but we don't have any. The fundus examination, both the eyes is normal. So, Meghanshi, can we have a look at the clinical picture or clinical photograph of the patient, please? Yes, so see, this is the right eye and the left eye of the patient. So in the right eye, we can see this shiny, glistening reflex at the center of the pupil. Then we need to dilate the pupil. So we have dilated the pupil in both the eyes, and in the right eye, we see this bright, glistening reflex at the center. And there is no opacity. So this is a well-centered PCIOL in the right eye. In the left eye, we can see the anterior capsular rim. So this white thing that you see in front, this is the anterior capsular rim. And this anterior capsular rim, this is actually we can see a part of the capsular axis. It's the margin of the capsular axis. Then we can see the IOL, but the shine of the IOL is a little bit blunted. Why? Because see, we can see this opacity behind it. If we had a slit lamp, then the slit lamp would show us the IOL. Here, the glistening white, the glistening of the IOL is not that prominent because it has been blunted because of this posterior capsule opacification. So we have a PCO in the left eye and we have a well-centered IOL in the right eye. So
Yes,
what
ma'am.
is our clinical diagnosis, Meghanshi?
And then the diagnosis, both the eyes pseudophakia with left eye posterior capsular opacification.
Correct. So we will come back to this case and discuss the management of this case. But before that, quickly tell me, what do we mean by pseudophakia?
Pseudophakia, pseudo means false and phakia means lens. So pseudophakia is a false lens.
Correct. Good. So basically, when we say that this patient is phakic, these are common terminologies which we use in clinical practice. When we say that this is a patient who's phakic, what does it mean? It means that the patient has a crystalline lens. It may be clear, it may be cataractous, but he has a crystalline lens. When I say this patient is aphakic, that is when I use the word aphakia, that means there is an absence of lens, absence of both crystalline lens as well as intraocular lens. There is no lens. Now, nowadays we don't get too many patients with aphakia. Previously, when we were doing many years back or decades back, when the common modality of management for cataract was intracapsular cataract extraction. Intracapsular cataract extraction, after the extraction of the cataractous lens, no IOL was implanted, so the patient would become aphakic. Nowadays, we can have traumatic aphakia, or if we have a lens which is displaced, then we can have aphakia. But otherwise, post-surgical aphakia is not very common nowadays. Post-surgically, what we have now is pseudophakia, which means that when we remove the crystalline lens, which is usually cataractous, what is the problem with a cataractous lens? A cataractous lens obstructs the pathway of light and it results in decrease in vision because you require a transparent ocular media. If the opacity of the lens is lost, or the crystalline lens is decreased or lost because of cataract, it obstructs the path of the light. So we need to remove it. But just removing it is not enough. We have to replace it with an artificial lens also, or an intraocular lens. Why? Because the lens is not just meant for allowing the light rays to pass through. It is also a refractive structure, which means it also participates in the bending of the light rays, right? So if you just remove the cataractous lens and leave the patient aphakic, that is going to solve only part of the problem. What we have to do is we have to replace it with an intraocular lens of suitable power. So that's where the term pseudophakia comes. So we remove the cataractous lens and we have replaced it with an intraocular or an artificial or a false lens, and that's why we call it as pseudophakia. Right?
Okay, ma'am.
So now, Meghanshi, will you tell me what are the different types of IOLs that we have?
Yes, ma'am. So, ma'am, most commonly we use posterior IOL. Then there could be anterior chamber IOL, iris fixated, and scleral fixated.
Correct. So the most common type of IOL that we have is what we saw in this case, that is PCIOL or posterior chamber IOL. And where do we want to put this IOL? The IOL is the ideal place for the placement of the IOL is the capsular bag. So as I discussed earlier, when you do a cataract surgery, you make an opening in the anterior capsule, which is called as capsular axis. Through this opening, you remove the cataractous lens, but you leave behind the capsular bag so that inside the capsular bag, you can place your intraocular lens. So that is a PCIOL, posterior chamber IOL. Now, what about the other types? The other types, that is anterior chamber IOL, iris fixated IOL, scleral fixated IOL, these are generally used if there is a condition where you are unable to put a PCIOL. Our goal of cataract surgery should be to put a PCIOL only. But suppose the patient already has a capsular bag which is torn, or during the surgery, because of some complication, we end up injuring or tearing the capsular bag so that we cannot put the IOL with the support of the capsule or the capsular bag. Then what we will do, then we will not be able to place the IOL in the posterior chamber. Then the option is we either have an anterior chamber IOL, or we stitch the IOL to the iris, that is iris fixated IOL, or we stitch the IOL to the sclera, that is a scleral fixated IOL. So these options of IOLs are to be exercised only if we are not able to place a PCR. Right? So now let me just go ahead and tell you what are the different types of PCIOLs that we have. The most commonly used IOL that we have is a monofocal IOL, the picture of which you can see on the left hand side. Now, in a monofocal IOL, so see, as the name tells us, the name is monofocal, meaning it's only one focus. So when this lens allows the focus of only the distant rays, that is the rays of light which are emanating from a distant object. So the rays of light coming from a distant object will easily focus on the retina. So if you have a proper monofocal IOL with a good lens power calculation, the patient after cataract surgery should not need any glasses for distance vision. So his distance vision should be normal without glasses. But this monofocal IOL, the light rays only from distance are focusing on the retina. But this is an artificial lens which will not be able to accommodate like a normal crystalline lens. So therefore, for the near rays will not focus to the retina, and for near vision, he will be requiring glasses. So if we have a pseudophakia with a monofocal IOL, the patient will have clear distance vision without glasses, but for near vision, he will need glass, right? But however, if we have a more premium segment IOL like a multifocal IOL, now see, the name itself tells us what it means, and in this picture also you can see that this IOL is showing us multiple rings. So what does this mean? It means that this IOL has multiple foci, meaning the rays coming from different distances are focused on the retina by the IOL itself. So this patient, if we have done a proper IOL power calculation for this patient, then a patient with a multifocal IOL will not require glasses both for distance as well as for near. But then these patients have a problem. These monofocal IOLs sometimes give rise to glare and halos due to scattering of light. That is a problem. But the good part is that they generally do not need glasses. They are spectacle free. Right? Now, there is also another new segment of IOL which are called as toric IOLs. Now, what do we mean by toric IOLs? Now, toric IOL means it's an IOL which has an incorporated cylindrical power. Now, why do you need to incorporate a cylindrical power in the IOL? Now, if the patient has a pre-existing corneal astigmatism, then taking the opportunity of this cataract surgery, we can actually incorporate that cylindrical power of the cornea into the IOL. And we can use the opportunity of the cataract surgery to correct his corneal astigmatism also. So that is the purpose of toric IOL. So see, here we have a line here. This is showing the axis of the incorporated cylinder basically. So the first one is a monofocal IOL with an incorporated toricity. So that's a monofocal toric IOL. And this is a multifocal IOL with an incorporated toricity. So this is a multifocal toric IOL. Okay, so these are the different types of IOLs that we have. Now see, in our patient, we have not done the near vision of the patient. So if you see that the unaided near vision of the patient is poor and it is improving with glasses, then you kind of know that it's a monofocal IOL which has been implanted. But if you see that the patient has got a good unaided near vision after pseudophakia, then you know that probably the IOL is a multifocal IOL, right? So now, after implanting the IOL, there are some malpositions that are possible. For us, the IOL in this case was central, but sometimes the IOL may just subluxate upwards or downwards, or it can have a pupillary capture, or it can keep moving if it is not properly placed. So these are possible malpositions of IOL which can give rise to decrease in vision. But however, none of them is present in our case. In our case, we have well-centered IOLs in both the eyes. Right? Now, but it's very important, as I told you, that the when we are implanting an intraocular lens, it's very, very important that we do a good IOL power calculation, because the lens is not just meant to transmit the light rays, it is also meant to bend the light rays to an adequate amount so that they will focus on the retina. So
Yes,
Meghanshi, will you tell me what is the common IOL power calculation formula that you know about?
Yes, ma'am. So commonly we use SRKT formula.
We use SRK formula. So will you please put on
Yes,
the slide of the IOL power? What is the common formula?
So, ma'am, in the SRK formula, that is Sanders Result graph formula, we have P is equals to A minus 0.9 K minus 2.5 L. There, P
Correct.
is the power of IOL and A is a constant which is differ for each lens, and K is the keratometry which is in diopters, and L is the axial length
which is in millimeters.
which is in millimeter.
Correct. So this is the standard IOL power calculation formula, where P, as you mentioned, is the power of the IOL. A is called as the lens manufacturer's constant, and the two variables that we are using for IOL power calculation are K, which is the curvature of the cornea, which is measured in which is the keratometry, which depicts the power of the cornea depending on the curvature of the cornea, and L is the axial length. So basically, the two parameters or variables which are required for an IOL power calculation essentially are keratometry, that is corneal power or curvature, and axial length. Now, this formula is a very, very basic formula, that is SRK2 formula. It works well if you have eyes which are in the emetropic range, that is, who have an axial length in the normal range, meaning they are not too small eyes or they are not too long eyes. Long eyes means they are myopic, and small eyes means they tend to be hypermetropic. But if we have patients who have a significant hypermetropia or you have a significant myopia, then this SRK2 formula will not work for them. So for these patients, we have to use other formulae. So what are the other formulae? For example, if we have patients who have long eyeballs, that is myopic patients, we use SRK-T formula. And for small eyes, we tend to use the Hoffer-Q formula. Right? Now, apart from this, there are some newer formulae also. Now, the newer formulae obviously give better results. But what is their main application? One of their important application is in complicated cases, that is eyes which are post some form of refractive surgery. What do I mean by that? I mean, for example, suppose I am a myope and today I undergo some form of corneal refractive surgery, like for example, say I undergo LASIK and I get my myopia corrected. And say another 20 years later, I develop cataract. Now, for these kind of eyes, which have previously undergone a corneal refractive procedure, none of these formula will work. So for these, you need far more advanced formulae, and these formulae like Hage's L, Barrett Universal, Hill RBF, Holaday, these are actually formulae which are useful in eyes which are post-refractive surgery, because in these formulae, what makes them better is, apart from this keratometry and axial length, many other parameters have been, or many other variables have been incorporated, and that makes these formulae far more accurate. Right? So what do we understand? We understand that to get a good pseudophakia, we need to have a good IOL power calculation. And depending on whether we have used a monofocal lens or multifocal lens, the patient will have different distance vision and near vision. So if it's a monofocal IOL, distance vision will be clear without glasses, but patient will need glasses for near vision. With a multifocal IOL, both distance and near vision will be clear without glasses, but the patient may have some complaint of glare and scattering of light. And if the patient has a pre-existing corneal astigmatism, it can be corrected by incorporating a toric IOL. Right? Okay. Now let's go back to our case. In the case, what was our diagnosis? Our diagnosis was the patient has both eyes pseudophakia. Right? But he has a posterior capsule opacification in the left eye, which is why he has come to us. So he has a decrease in vision in the left eye because of opacification of the posterior capsule. So how will you manage this patient? How will you help him?
Ma'am, for posterior capsular opacification, we have treatment like neodymium lag laser.
Correct. So we have to do a capsulotomy for this patient. What do I mean by capsulotomy? It means making a hole in the posterior capsule. So at the center of the posterior capsule, I will make a cruciate opening with the help of laser. How is that going to help? See, the posterior capsule, because it became opaque, once again, the path of light has been obstructed. So if I clear the visual axis by creating a small cruciate opening at the center of the visual axis, the lens will still remain in position, but the visual axis will become clear, and this will allow the patient's vision to improve. And this is done with ND-YAG laser, and that's why the name ND-YAG capsulotomy. So the management for our patient is ND-YAG capsulotomy, and after that, if required, we will do a refraction for the patient to see how much improvement in his vision is happening. Right? So this was a case discussion on a very, very common case, that is pseudophakia, and one of the common problems that happen a few years after cataract surgery, that is PCO. And I hope that this has solved the doubts of you, Meghanshi, and also the other students.
Yes, ma'am. Thank you, ma'am.